Warm word of welcome to you. Because we're such a small group, I'm going to keep it relatively informal. My name is Swart, and I'm from the Faculty of Health Sciences, and this is what we're going to talk a little bit about. We're going to talk a little bit about health and wellness. We're going to look at what is health. What is our general perception about health in South Africa? We've got some people from the faculty here, people that studying health around disciplines. But secondly, why is health so important for us, and how does it play out in our international positioning? Because I think a lot of people don't really understand the importance of the healthcare system and the indicators when we talk about international positioning. Then we're going to look at the context of healthcare, some key aspects for considerations. Then I'm going to focus specifically on some areas of concern, especially for young South Africans, with some figures and stuff. But I think the whole health system is important for young South Africans, as it is for every single South African. We're going to make some concluding remarks, and we'll have an opportunity, if you want to talk a little bit, ask a few questions, etc., to talk about that. So what is health? Let's just hear from you. What is your understanding of health? Let's hear.
I think it's taking good care of one's physical needs so that you can always be functional.
Very important aspect. She's giving us two messages. She says one part of health is physical health. How do I take care of myself? But a very important message she's saying is that in health we've got the responsibility, because she used the word, I've got to take care of myself. Okay? Any other issues? Prof. Cooper? Now I've got to be careful here.
No, to add what the last speaker said, obviously mental, social, psychological.
Okay. So when we look at health, many people would say it's just the absence of disease. So when people don't get sick, we have a good health system. But what do we mean by when people don't get sick? Is it just diseases, communicable diseases as we know? So nobody gets heart attacks, nobody has high blood pressure, nobody has diabetes, we're a very healthy nation. Or does it translate to the physical, the emotional, and the social? Because can we be healthy if we live in an extremely unhappy household? No, because mentally we did not adjusted. So I can be physically very fit and healthy, but when I'm emotionally not adjusted, then I'm not healthy, all right? And that's the whole issue around mental health. So it's not just the absence of disease, it's not just access to good health care or access to food. That's a real story in South Africa. Water and sanitation. Very important aspect, and we'll talk a little bit about it later, is the whole important role of the social determinants of health. So as we sit here with a group of spread ages in this group, some youngsters that's studying, some colleagues that's working, we understand that the social determinants was probably one of the key determining factors of health today. So people with higher educational levels are normally associated with better health. Why? Because they have better housing, they can afford medical aid, they have cars, they can afford better food, etc., etc. So social determinants are a very important aspect in South Africa because of the history of the country. When we look at housing, access to work, and a range of other issues, is a very important issue. And I want to get this one out of the way now before we start talking some facts and figures and a range of other issues. Why is health important for us internationally? So we're talking a lot about health, and you would often hear that health, if we look at the allocation of our budget, health is one of the top three. We know security is a big issue in our country. We know, secondly, that schooling, higher education and schooling is one of the top three. And then health is always one of the top three. Many times it's one of the top two. Why is it so important? Because the status of health is important. We don't want our people to die. It's very important. But why do you think in an international profile is the health status of society so important? Very few people know this, but if you as a country apply for international funding, either from the IMF, the International Monetary Fund, or other international funding for development, one of the key factors the funders would look at is your health status. They will say, how many women die in childbirth? How many children die before they turn 5 years old? How many children die in their first year of life? Because surely the potential for you to repay the money will depend on your development or developed potential as it is. And if you haven't got a health sector that's truly working, it shows that you haven't got a developed nation that will put your risk of paying the funds back. So health is a very important aspect in positioning yourself internationally. What's the biggest money spinner in the country for our gross domestic produce? So if we want to look at funding, what is the key drivers of our economy? Mining used to be the biggest one, am I right? Thank you for agreeing with me. So mining used to be the biggest one. What is the biggest one today?
I wanted to say tourism.
Tourism, okay. So would a lot of tourists come to a country where there's no health infrastructural development? Would you travel to a country, if you go there and they say, hey, people die every day, when you get sick, there's nothing that can happen. Will you travel to a country like that? You're a student, you will go because you have no budget to go anywhere else, eh? No, I'm only joking with them. But the reality is that this is a very key important aspect for us to take forward. So when we look at the burden of disease, that's the disease profile in a country, it impacts on how much money we require for healthcare services, how do we provide healthcare services, and what's our positioning globally. I'm going to give you an example. If we look at the United States of America, all right? If we look at their healthcare system, what would you think? The world's biggest economy, do you think they have a brilliant healthcare system?
I think so.
We think so. Most of us would say so. But if you look at the group of 34 countries, the most profile economic countries, the so-called developed nations of the world, 34. America comes in number 1 for the amount of money they provide for healthcare services. They put in 18%, and we're going to talk a little bit about it later. Please come in, have a seat. They put in 18% of their gross domestic produce. They put into the healthcare system. But if we look at outcomes, where do you think they rank in that 34 countries? Just have a guess, don't be shy. In the top 10, 10 to 20, 20 to 50, above 50?
10 to 20.
10 to 20, this is a guess. It's nice to say to a professor he's wrong there. No, it's not there. Guess where do they come in? Number 33. Number 1 for investment, second last out of that 35 nations for outcomes, all right? So it's very important that we look at this, and we're going to come back to this a little bit later, because these are the 4 key areas that drive healthcare in South Africa. And we're going to unbundle this a little bit more. So if we then look at the context of health, and we talk about healthcare in any country, whether it's South Africa or any other country, there's 3 key pillars that drive healthcare. The one is legislation, because if we don't have legislation that can enable healthcare, funding, facilities, hospitals, care, regulate how people will be trained. We cannot just train a chiropractor any way we want to train a chiropractor. There's a scope of profession that governs that. We cannot train a nurse as we think we want to train a nurse, because there's a scope of profession that governs it. Same with a range of other disciplines. And it also says, how do we allocate money? What range of issues we do. We talk about health insurance, and in this instance, I'm not talking about the national health insurance scheme. I'm talking, as we know it, internationally it's known as health insurance. We refer to it as medical aid. Okay. So how many South Africans do you think have got access to medical aid? Percentage-wise? To medical aid, 70%. 40%. Any other guesses?
Say 50.
50%. It's always nice the middle of the road, eh? No, let's hear. What? Any other guesses?
15%.
You're quite close. It's less than 20%. Between 18 and 20%. What does that mean? I mean, now I need to talk to you, because what does that mean? If I say to you, less than 20% of South Africans has got medical aid, health insurance. So what does that mean? 80% of the population are reliant on public healthcare facilities. And who funds public healthcare facilities? The government, all right? So you see the implication around this. Understand why it's one of the top 3, not just because of the burden of disease, but also because of the nation of the the history of the country, and 80% of the population that require access to that. So I don't want to talk too much around that. We know that national health insurance is being looked at for the country, and also the National Developmental Plan talks a lot about how do we get accessible, affordable healthcare for all members of society. Then there's the economic perspective. How much money do we spend on healthcare? So the legislative framework will create the environment for us to allocate money for healthcare services. South Africa, and many of you might not know this, it's one of our big problems we have in accessing international funding. We're seen as a middle-income developed nation. So although we know in our own country there's significant problems around development, we know that we still need to go a long road with housing for everybody, appropriate housing for everybody, access to facilities, but the international world see us as a middle-income developed country. So when we compete for international funding, and we compete for argument's sake with Zambia or with some of the DRC or other developing nations, we've got very similar needs in various of our environments, but because of the income of the country, we're seen as a middle-income developed nation. Okay, we're going to talk a little bit about the expenditure on health and understand how much we spend on health per person in this country. We'll get to that a little bit later. And why is it so important to try and reduce that? And one of the things that I'm going to put to you already now, in South Africa, we spend between 8.4 and 10% on healthcare, depending how you calculate it, of the GDP. The World Health Organization says we should not be spending more than 6.4%. So the World Health Organization is saying we're overspending. Now all of us, as we sit in this room, and we've got a wonderful Minister of Health, I've got the utmost respect for him, but is health service really delivering what they should be delivering? You open a newspaper, there's problems at hospitals, eh? And it's not his fault, because remember, health services is a provincial allocation, and not, let's not take poor Minister Motsoaledi apart here, because he's really a very committed and a really good guy. So I want to talk about two issues very quickly before we get to some figures, the wealth gap and inequality, because the two talk directly to each other. So if we talk about the wealth gap, that's the income between the poorest and the so-called upper levels, the rich people. And you know that we hold the record in the world for the country with the biggest wealth gap. It's a very unfortunate record we have. We don't want to be number one in the world, but we are for at least 3 years now. Previous country that held that was Brazil, the biggest income gap. But South Africa, if we look at the Gini coefficient, we're going to look at that in a table a little bit later, we're touching 0.7, which is the highest in the world. That means we've got the biggest gap in the world between lower income people and rich income people. The interesting thing, if you want to be in South Africa, if you want to be categorized in the top 20% of people income, the top 20%, what do you think you need to earn a month to be in the top 20% of income earners in South Africa? Hey, I see my colleagues here saying, hey, not me at the university, eh? No, but you're going to be surprised. So what? Just have a guess. I mean, we're having it very informal. Let me start with the chiropractic student and just say, so in the top 20% of income earners in the country, what do you need to earn a month? 60 G's a month, eh? All right? Sure, I hear this side, eh? What would you say?
I was going to say
20 G's, all right? Let me just give everybody a chance. Let me go down the line, yeah.
I'll go with
40 G's. Hey, now it's becoming difficult. There's no calculators we need to sort out now. What do you say? 50 G's.
60.
60 G's. 50.
At least 25.
25 G's.
I'd say 30.
30 G's. Now I'm involving everybody, whether they're working or not, yeah.
I'm going to say 5.
5. Yeah, it's a bit low. It's a bit low, yeah.
I would say
50. The 20 was very close. And you were just too low. 16,000 rands a month.
16.
1/6. So, people sitting in this room, working at the university, many of them, most of them are in the top 20% of earners in the country. What does that tell us? If that is the top 20% starts at 16%, what does it tell us about the significance of the gap? Massive gap. Do you see that? Now, in that top 20%, if it starts at 16,000, then you know there's huge stratification in that top. So we will literally go from 16,000 a month to 200, 300, 400,000 rands a month in that top stratification. But you do understand, you see the worry that 16,000 will bring you in the top 20%. So what does this other people earn in real terms when we go down to that? The third one I want to talk quickly about is am I boring you? Are you on the right track? You're learning, you're listening here. You must tell me if you want me to change a bit of the issues. Epidemiological context. So we speak about, this is the disease burden, all right? So it's the prevalence of disease. What are the real drivers in the country? Quadruple burden of disease. We're going to get to it again just now. Life expectancy, mortality and morbidity. How many people die and how many people get sick? And once again, the social determinants of health that we spoke around my opening slide. So I'm not going to talk too much around this. I just want to say there is a very strong legislative mandate. Health is about people. So the Constitution is very clear that everybody should have access to appropriate healthcare services. It's also got a Bill of Rights, which I want you just to park a little bit, saying that everything we have in this country should be done in such a way that there's no activities that becomes detrimental to health. That every single citizen of this country should have access to potable clean water, should have appropriate housing, should have access to affordable, equitable health care and a range of other issues. But let's look at the economic perspective. Also, I spoke about this quite a bit. Middle income development country, we spent around 8.4 to 10% on health. Wealth gap is the most biggest in the world. Now, this is the real frightening things. If we look at the international poverty line, South Africa falls within 10 to 30% of population range. A lot of the poorest countries in the world fall more centrally. And the reason for this, that we fall in the 10 to 30 percentile range, is because of the significant gap. But listen what I'm saying to you here. In South Africa, 11% of the population, there's an international poverty line. And the international poverty line is $1 a day. All right, so currently, let's just say it's 12 rands a day, if we look at current exchange rate. Then there's an adjusted international poverty line, which is $2 a day. Let's say 24 rands a day. Look at those figures. 11% of our population live on the $1 a day. Up to 30% of our population, little over, live on the internationally adjusted poverty line. Now, many times you hear people talk about the social context of health. And we talk about social grants, and it's a big story with many people. We hear many people say, hey, 16 million people on social grants, this country cannot afford it, we should do away with it. You've heard that arguments, haven't you? You hear the debate, but hey, we only have 9 million active taxpayers, 16 million people on social grants, we can never afford this. Imagine what would have happened to those groupings if they didn't have the social grants. Now I want you to just think 1 minute. You're a mother, 2 small children, I'm not even going to make lots of children, 2 small children living in a rural village. You've got to get to a primary healthcare clinic that's 15 kilometers away, because although we want them closer, we know they're not closer. You live on the adjusted international poverty line, so you're getting 25 rands, 24, 25 rands a day. You've got to look for food, you've got to buy clothing. You've now got to spend 10 rands taking a taxi to the clinic because the youngest one is sick. But you've still got to buy either some eggs or some maize or some milk with the 25 rands. What are you going to do? Think about it. What are you going to do? You've got 25 rands. Difficult decision, eh? Can you now see why so many young kids in especially rural areas don't get to healthcare facilities? It's just no money for the taxis and stuff to get there. See what the impact on our healthcare system is. And this is a reality. We would liberally, and you all are working because you're getting some extra income as peer tutors and a range of other issues. But how easily would we spend 10 rands on 12 rands on a Coke and a chocolate? Quite easy, eh? Let's be honest around it. Now think back again. If you had to make the choice, you had to feed 3 mouths with that money, what would you have done? And this is the harsh realities that's facing everybody, or not everybody, a significant bulk of our communities in South Africa every day. Now you would say to me, but Prof. Swart, I thought we're talking about health. But isn't access to food health? What did we say earlier? Physical wellness, emotional wellness, overall goodness. All right, so it's also religious, spiritual, everything. But can you have good health even if I'm physically healthy? I'm not getting sick, but I don't have proper food to eat. Am I healthy? No, clearly, you see these lines. Now look at that last point I'm making there for you. This is South African figures. 2012, and it's actually the gap has grown the last couple of years. Poorest 20% of people in this country, if we look at their expenditure countrywide, only 2.8% of all expenditure in the country. So that's rates and taxes, that's buying food, that's traveling, you name it, where there's expenses. 2.8. The wealthiest 20%, 64.5%, 65 of all outcome spending patterns in this country. And obviously in the gap in the middle is the differences between them. But look at that. Poorest 20%, only 2.8% of all expenditure in this country. A fifth of the country's population spend less than 3% on expenses in the country. One of the biggest challenges we have in South Africa is our so-called quadruple burden of disease. So we've got a problem that we've got to face from 4 fronts. First one is HIV, AIDS and TB. Our significant levels of violence and associated trauma is resulting from that in society. Our infant and maternal mortality rates. I'll talk a little bit about that and explain to you how we calculated that. Then a very important aspect which I'll come back to later, the so-called non-communicable diseases. So is HIV big for us? We saw today we're spreading ARVs. I mean, it's most probably the most significant intervention in the history of the country when existing President Zuma took that decision to say we will provide ARVs after all the years of Mbeki denialism that said no, let's stick to beetroot and the African potato and we all smell like garlic, HIV will run away and all kinds of stories. You remember those debates? With Mantu and everybody, absolute denialism. So is it still a problem?
It's controllable. The mortality has actually dropped for the past 10 years now.
It has become much better, but just to put it into context, 5.7 million cases in South Africa. If you look at the context of South Africa globally, we've got 0.7% of the world population, 0.7% of the world population, but we've got 17% of the world HIV cases. You understand the context? Now, although we say we're managing it, and we are managing it, there's no doubt around that. Mother-to-child transmissions is nearly at zero. It's nearly at zero. In provinces where there's a problem still with figures, like Free State, some parts of KZN, it's not because we're not rolling out ARVs, it's because of poor mismanagement of the related budgets in those domains. We've done significant work on it. We've gone absolutely wonderful programs, but what is the frightening thing around HIV at the moment? We've stabilized infections 16 to 24. There's very little new infections, but there's a high level of complacency starting, especially amongst young people. The approach is now, why worry about safe sex? Because there's a treatment. If they've got an ARV, it can help me. Very soon they're going to have a medicine that's going to cure me. So there's a certain level of complacency, and this is one of the bigger threats, especially with young South Africans, that they're becoming complacent towards all the interventions we've had. And the more we're talking about our success stories around HIV, the more complacent they are becoming, and the more we're moving back into risky sexual behavior that could lead to an upsurge once again. I think some of you might have seen the report from various universities related to HIV/AIDS at varsities. And absolutely the frightening figures with young South Africans saying it's not something that will impact on me, and if I do get sick, it will be something sorted. There will be a cure in the next 4 or 5 years. I haven't heard for a long time about people dying around it. So why worry about the safe sexual practices? So you see, it's a real concern for us because we never want to go back to where we were. And obviously because of the costing associated with it. You'll see that if we look at ARVs, antiretrovirals, we use 27% of all ARVs produced in the world. 27% of all ARVs in the world. One of the big issues, it's a big debate that HIV/AIDS is a non-notifiable disease. If we look at the Health Act, there's a whole list of diseases. So if we get cholera, malaria, even food poisoning, a whole range of diseases. If you see your doctor must report it. And the reason why they didn't make HIV/AIDS a communicable disease because of the associated stigma that was attached over the years. And then they were afraid people will never go and report on it. So it's still a big debate around that. Should we make it a notifiable disease or should we not make it a notifiable disease? But the significant challenge we have, look at that, and this is really frightening, is the link between HIV/AIDS and TB in this country. You know that we've got not just the highest HIV load in the world, we've also got the highest TB load in the world. And the frightening thing about TB, it's a purely treatable disease. So you've got to take your medication, but there's some factors combined with that, such as nutrition, such as proper ventilation in the house where you stay. Water and sanitation should be available. Then I'll give you an example now. But if we look at these figures in red that I've given to you, that's the number of people per 100,000 deaths in the country. So if we look at the 100,000 deaths in the country, so many people die as a result of tuberculosis. Okay? Now you might say it's not a lot because of 100,000 deaths, but significantly high. In 1997, we only had 57 people dying per 100,000 resulting from TB. Our latest stats 2 years ago is in excess of 300 already. So you can see we're losing that war. It's a war, I want to call it a war. We're losing it completely. Where the Western Cape was the province with the biggest problem, it's moved now to the Northern Cape as well. So it's the Northern Cape, a proportionate 1,000 population, has got higher infections than the Western Cape now. But even more significantly so, is it links with HIV/AIDS, because the one piggybacks on the other one. So once I've got HIV/AIDS, I become much more susceptible for TB, because my resistance is low. Conversely, once I've got TB, I'm also much more susceptible, if I don't follow safe protocols and a range of other issues, to become susceptible for HIV/AIDS. But you can see it is a real problem. And we've also now found that in South Africa, the only place in the world where it's so prevalent, multiple drug resistant and extreme drug resistant TB. Because how do we develop multiple or extreme drug resistant TB? That's when you don't take your medication. It's the same when you have flu and your doctor prescribes, or antibiotics will not work for flu, but it covers the associated complications of infection and a range of other issues. So if you're supposed to take your medication over a 6 months period and you stop taking it over 3 months, we cannot start you on the same treatment protocol. You've got to take a much stronger antibiotic, because your body has developed, it's mutated, and it's resistant to that strain now. So we only have so many strains of drugs we can use in the war against TB. So every time somebody doesn't take their drugs, they move closer to the edge. And ultimately, when you've deviated from your treatment protocol over such a long period of time, you'll get to extreme drug resistant. And what happens when you become extreme drug resistant? The Act says we must take you and lock you up in a hospital in a separate ward, because it's very contagious, all right? So I don't know how many of you followed the news that about 2 years ago, there's somebody that was locked up and took the hospital to court and everything. It's literally locked up in a ward, because you cannot be in contact with anybody else, because it's just so contagious. And that's why in South Africa we've got a system which we refer to TB mentors, TB ladies that goes around from house to house, and they have a system, and you actually have to drink your medication in front of her and she records it on her iPad. Whether it's urban, rural areas, because the risk is just so high if we don't use it that way. Some frightening figures. Mortality figures, I just want you to look at this, and this is really, really very worrying. So if we look at infant mortality rates, we get maternal mortality rates, that's children that die within the first year of birth, and infant mortality rates within the first 5 years of birth. And that's expressed as deaths per 1,000. When we look at maternal mortality rates, MMR, that's expressed as deaths, women that die in childbirth due to various complications. And you can see if you look at infant mortality rates, South Africa is 53.1 children dying, Brazil 17.3 and Mexico 14.7. That rate I've put for you for South Africa, and that was our Millennium Developmental Target. Remember that ends this year? And with the Millennium Developmental Goals, a lot of them cuts across sociology, education. That was the Millennium Developmental Goals. But look at the under 5 mortality. We're at 104 still, and the target was 20. But look at maternal mortality. It was above 600. The target is 58. So if we pull HIV out of that, it will take away close to 50%. But the good news is that the last 2 years there's been significant inroads, and if we pull HIV/AIDS out of the equation, we're around 150 now, because that figure includes HIV/AIDS. But you see, 150 is still a mile away from 58 where we want to go to. Now, look at the impact of this on society, and you that study social work will understand. Because when a mother dies in childbirth, what do we have? We have another probability of a child headed home. Huge complications. Who cares for them? How do they get through schooling? The whole notion of our society, when mothers drop away and youngsters continue to fall pregnant, because we've got a social grant around it as well. So they get caught in a trap, and we know that the trap they want to get out is for people to get education, that they can get employed and escape out of this poverty trap and take that forward. And then just quickly, trauma associated with violence. Now, this is another sad story, unfortunately, for us as South Africans. Because it's extremely costly. It's trauma associated with various of violence. So it's one-on-one violence, it's accidents, it's domestic violence, but it also includes accidents on our roads, whether it's pedestrians that's being hit or motor vehicle accidents. And we know that's a problem in our country, right? We know it every year over December month, more than 1,000 South Africans die on our roads. So what do you think, if we look at deaths as a result of trauma associated with violence, and I've highlighted it to you now, what do you think is the international average? 87, all right? 87 per 100,000 deaths internationally for trauma associated with violence. For argument's sake, we get students from some of the Norway countries, Denmark, other countries, Norway. Lots of medical practitioners come over here, especially trauma specialists in their specialization here, because you will have to work in some of those countries up to 18 months to see one gunshot chest. Up to 18 months in a trauma before you can qualify to see one gunshot chest. Put him one weekend either in Charlotte Makeke or Chris Harney, 5-6 gunshot chests, so they do their practicals very quickly, So 86, closer to 87. What do you think is the continental average? So for Africa, our continent, what's the average? If the international average is 86, 87, what would be the continental average? Hey, I'm making you guess too much today. Tomorrow you'll give me the lotto numbers. But what do you feel?
90.
90?
80.
80, you think the continent will be lower than the international average? I think because internationally we've got, as I said, in Sweden, Denmark, these very little cases around us. They've got very strict laws around motor vehicles, very limited. So it will be a little bit higher. All right, so the continental average is 127. But remember, there's also war on our continent, so we've just got to understand that. So what do you think is South Africa's average? Now you're all smiling. It's like I'm asking you. Now, what do you think is South Africa's average? Have a guess. Lower or higher than the continental average? Higher. 136. 127 continental, 136 our average. See, we've got significant pressures in our healthcare system. Now, a lot of you, and this is what this talk is about, I'm talking to the more junior than me people, but especially for the younger people as well, is why is it so important for you to know these issues? Because this is money that could have been spent on education, on putting more people through university. Are you with me what I'm trying to say? It's very important to understand this context and taking it forward. Then NCDs, and then I'm going to finish off in the next 7 minutes, the non-communicable diseases. The interesting thing about non-communicable diseases, we've got full control over managing it. But in the next 10 years, not even by 2050, in the next 10 years, this will kill more people in South Africa than HIV, AIDS and TB put together. It will kill more people in South Africa than HIV and TB put together. Secondly, it's not a South African issue, it's a worldwide issue. So these issues that we're talking, diseases associated with lifestyle, whether it's obesity, whether it's inactivity, whether it's high blood pressure, you name it, and there's a few of them I've put out for them. It's a worldwide aspect. In the history of the United Nations, they've only had 2 special meetings for health. In the history of the United Nations, only 2 special meetings for health. The first one was for HIV/AIDS. The second one 2 years ago was for the non-communicable diseases. That's how serious issue it is, all right? So I've also asked a question around mental health. Because when we talk about NCDs, we talk very quickly about diabetes, we talk about high blood pressure, we talk about obesity, unhealthy lifestyles. But the whole issue, mental health, is also a non-communicable disease because of the high levels of pressure in our society. Now, remember the examples I gave you, being a mother with the international poverty allocation or the adjusted international poverty allocation. Do you think a person that's got all those worries every day can have proper mental health? It's impossible, eh? I mean, we live in the cities. You worry about, am I going to pass this year? It affects your psychological being, am I right? People has got money stresses. Kids get sick, they have extra money to spend. It affects them, and it's one of the most underrated NCDs that people don't talk about. Because once again, the world has become a very small place. Those of you that's followed the Greek debacle, you've seen that they had a referendum, and the referendum was say, no, we're not going to pay back the money. The outcome is there. I don't know if you've seen it this morning. Eh? And I'm not talking about in Kandla now. Don't smile here. I'm talking about Greece here now. So, but the real big issue around that, they must probably be kicked out of the European community, the European Union. What's the impact for them? So poverty, financial problems, whether you're in the States, anywhere. I travel every year to the States with 11 of our top performing students. And the one thing that struck the students is one day we went to a private university, Wake Forest, where they do the most incredible work. This little Pippa Kruger, you know, the girl that burned herself 2 years ago. They grew a skin for her at that university. They actually grow a new kidney in front of you from your own stem cells. You can see them growing it there. And we went out of this one mall, and the student said to me, Prof, I cannot believe what we're seeing, because we saw a white pregnant lady standing with a placard saying, unemployed, please help me, I need money. And we think it's a South African issue. You're in the middle of America, you go to the UK, you travel the world. Prof Cooper will tell you, also travels quite often for conferences and work. I travel just as much. It's a worldwide issue. So mental health is a real issue. But much more important is this whole aspect. Look at those. And this figures has changed in the last year. Obesity in South Africa, adults 20 plus. Males over 20% obese, females over 40% obese. In fact, females in our country is pushing towards the 50% now. And if you look at certain indicators, we actually, excuse my terminology, the fattest nation in the world. I cannot put it in a nice way. Even in certain indicators, Prof. Cooper's done research on this, we overtaken America in certain indicators. And one of those areas we're overtaking in America is in our female obesity rate, in our adult female obesity rate.
At least we still have got those small beggars. The American ones that are huge. Yeah, we need to
Just saying, these are facts. These are real facts. So these are real worries for us. So I just want to talk quickly about this. We haven't alluded to them a lot because we don't have too much time, but there's also real risk factors that contribute to the healthcare sector. Undernutrition, we've spoken about that. Unsafe water or access to potable water. You know, there's still too many South Africans that don't have access to, they have access to potable water, but do they have access to a suitable amount of potable water? You know, we've got this aspect in South Africa that, and I understand because it's a developmental issue, and we've increased, remember, 94, advent of democracy, 60-70% of the population, especially in rural areas, didn't have access to water. Didn't have access to water. So we've moved that to early 90%. It's a wonderful job we've done. But for many of them, the water is still 200 meters away from their house. Many of you know this. You go to many rural areas, the water's not even in the tap, on the stand, still 200 meters away. Who's the main collector of those waters? Women and children. Economically, how does it impact on their health? Have we thought about that? Now we also know that the access, that water should run consistently at full level for a certain amount of hours every day. And we know that doesn't happen. So sometimes people will go and sit in the sun, in the queue, 4 or 5 hours to get access to water. What do they start doing? They'll have containers catching rainwater. When that first rain comes, the roof's full of dust, all kinds of problems, they all become sick. So the little ones become sick, you rush them off to hospital, they lie on an IV for 3 days in ICU. What do? We send them back to exactly the same environment. 6 months later, they're back in ICU. You look at the costs around us. So if we invest the money in providing proper infrastructure, it will also reduce the subsequent cost that we had. The whole notion about our education system and our housing provision. I mean, we've done wonders in providing housing. Remember, we've built nearly 3 million RDP houses. The key question we should ask, and I must be careful how I express this, because Ndiwe Sisulu in the 90s, when she was Minister of Housing, she nearly bit my head off when I asked her this question at the conference. She was very upset with me. And the point I made was, it's absolutely wonderful work they've been doing in building this nearly 3 million houses. The question I posed, would it not have been better, instead of providing 3 million houses, to provide 2 million houses with water on site, with sanitation at works, that houses that don't have to be demolished, with houses that's planned in such a way, with lintels, that we can just add a room 3 years down the line. Because I personally found that many of these houses has been designed, so when people were living in a 30 meter, 40 meter square shack, all that they did, with corrugated iron, they moved to a 30, 40 square meter house with bricks. But without services. So have we really contributed? Oh, and I was pulling apart. But the aim was not to say they're doing the wrong thing. I'm just saying, should we not have delivered higher quality over a longer period with shorter interventions? Because how many of those is people not able to stay in them anymore? We know the history. Many of them had to be demolished. Builders took their money, ran away, left unfinished range. We see examples, Gauteng, Mpumalanga, all over the country. So these are a very important issue. Is our education system really equipping youngsters to think for themselves, understanding where they want to go? Because this all impacts on health. Because you see how broad health is. It's not just a smaller version. Very quickly, just hunger. So underweight South African children between 6 and 71 months, 9% of children is totally underweight. And I think in the last year this will have increased. Wasting, that means you're underweight for your height. The target is 1.3%, 3.6% of kids are there. Stunting, so you don't get enough nutrition, so you don't grow like you should grow, so you're actually stunted in your growth patterns. Target is 11, say 12%, we're sitting at 24%. Real worrying things. And what I've done here, just quickly to summarize it all for you, I've given you a comparative example of health expenditure, health outcomes, and Gini indices. So if you look upper middle income countries, we can see Mexico, Chile, South Africa is in that grouping. We look at the gross domestic produce per capita in US dollars. So you can see South Africa there is 2,584. That's what our economy generates per person in the country. All right, whether it's tourism, mining, leisure, doesn't matter what it is. On the next row, we see the health expenditure, the public expenditure per capita in US dollars. We see Mexico is spending $241. So that's what the government is spending per person on healthcare. And look at South Africa, we're spending $270. Now what I want you to focus on here is that although we're in the lower levels of the upper middle income countries' GDP, we see we're not the top there, we're not even in the top 3. We're in the top number spending on healthcare, we're in the top 3. So now when we go to the next column and the health outcomes, look in South Africa, it's changed the last 2 years. This is data from 2010, as you can see in the reference. Now at least a male in South Africa, the adjusted life expectancy is around 57 and a female is just over 60 years. But look for that investment. Life expectancy at birth in South Africa is on average only 52 years. Look at the other countries, 76, 78, 75. Botswana, we also know that they've got a serious HIV problem as well, okay? But look at Algeria. I want to give you that example of Algeria. Look at their GDP per capita income. Look at what they're spending on healthcare and look at their outcomes. Eh? You see those figures? And then below, I've given you lower middle income countries. And you can see even countries like Cameroon, that spends $23 per capita, has got a higher life expectancy than people in South Africa. Remember what I said to you in my opening statements? We're spending 8.4, between 8.4 and 10%, depending what figures you use. The WHO, we should only be spending 6.4%, you can see the reason. So the key question we need to ask also as South Africans, when we invest so much money, why don't we have the related outcomes? Why do we have so many mothers dying? Why do we have so many kids dying? Why don't we have better healthcare facilities? So what is the problem? What is the real problem around that? Just very close to the end now, is that for young South Africans, this is a study that Professor Cooper was a part of and a number of other people. If we look at worldwide, 50% of deaths caused by chronic diseases, which we can control, obviously, if we play a role. Remember the opening statement you made, which I said, we've all got to take responsibility for our own health. But look at here, 4 key factors placing young South Africans at risk. 30% report smoking, young South Africans. Only around 50% eat fresh fruit and vegetables, but 48% they eat cakes and biscuits all the time. That's no problem. Physical inactivity. When I came up here, the young lady had brought me up here, I said we can take the stairs. She says, no, it's too far, it's fine, we can use the lift. So now I don't mind the stairs because my colleagues will tell you because we need to stay active because activity is good for us. 64% of girls, 45% of boys, little or no moderate or vigorous activity. So half of the population is doing nothing. We can see that translate back to the obesity issues. You see the figures I've given you earlier. But a lot of the youngsters have got up to 9 hours a day doing nothing, just sitting. It's so cool, eh? 3 hours television viewing every day. And some of them see that as an activity included in the 9 hours. Now, unfortunately, the slide, but just to give you the obesity, more than 30% of young girls and 10% of your young boys overweight obese, 22% of primary school girls and 17% of boys overweight obese. You see, but once again, I don't want us to miss this. There's a number of factors that play in here. So obviously health education is very important, educating people, making them aware about the challenges of not being weight. But once again, what do you do if we don't create enough jobs in South Africa where people have an income stream to eat better? Because you must understand that a lot of this is associated with the inequalities in our life and our income streams related to that. So, one or two concluding remarks. Health and wellness, clearly you can see, is very important for all of us in South Africa. It's a very important aspect. But it's also very important that all of us take personal responsibility for our health. We need to do something. Whether we walk a few flights of stairs, Prof. Cooper will tell you research that they've done. Just walking up 3 or 4 stairs once or twice a day will reduce your risk of diabetes by 20-30%. Just doing that. It doesn't mean you have to go to the gym. It doesn't mean you have to become a marathon runner. All right? So it's, do I walk? Like I personally take the stairs on campus. I ride it once. I don't drive it, I ride it once a day when I get out of the gym in the morning. But the rest of the day, even when I come to this campus, I walk. And I easily walk between 6 and 10 kilometers a day. Just walking. You'll be surprised when you walk from the parking to the Sanlam Auditorium, how many steps it is, and back. So you can quickly just add up a few steps and it will get you physical active, you know. So it will manage a range of these issues of the NDP, and this is where the government's plan is to take us all by 2030, all right? All to have a life expectancy around 70 years. Tuberculosis prevention and cure progressively improved, so we want to reduce that significantly. Much reduction, significant reduction in the number of mothers dying and young children dying. Reduce prevalence of NCDs by 28%. And this is very important for us because if we don't manage that, we're going to have serious problems for the future. Injury, accidents and violence reduced by 50% from 2010 levels because it's sky high. You see, so they also, just to reduce it by 50%, they've given themselves a 20-year window. Really significant. And also that we need to reform the healthcare system. We cannot continue working this way, where we're just treating disease. So we've got to get much more to a promotive, preventative approach, where people take responsibility for their health, and we don't just treat disease all the time. And the last one, I think, is very important, especially for us as a university, that we train people that's truly skilled, committed, and has the right competencies for the challenges in our healthcare sector. Not just the existing challenges, but also the new healthcare challenges. And that's my story. Thank you very much. I don't know if there's any specific questions. Nothing. Hey, then I've done a good job. If there's no questions, I must thank myself then.
No, I'm just thinking the issue of just taking stairs, maybe when going to the office, just up and down, would it really help?
We must actually get Prof. Cooper to do a short presentation for staff on studies and stuff that's happening related to that. Because people don't understand just a little bit of activity. How it kickstarts your metabolism, how it changes how you look at issues, how it will start changing your eating habits. Even if you're on a tight budget, there's small things you can change that will contribute to this healthy lifestyle and will reduce. And I mean, diabetes is the real new problem. It's the, excuse the terminology, but it's the HIV trouble of the future. It's not the HIV, don't misunderstand me, but it's going to kill the same number of people. You know, on the continent, 70% of amputations, lower limb amputations, either the lower foot or from the knee down, 70% results from diabetic ulcers. And 70% of amputations could have been prevented if people had better care and taken better care of themselves. Now just think when somebody loses a lower limb, the cost to their lifestyle, the possibility of a job. If you look at the implications, the problem they have in their family adjusting, the family adjusting to them, how they live, their mental health adjusting. It's a preventable issue by a little bit of exercise, seeing the warning signs. Most of us is on medical aid. It's not going to cost you a huge, test yourself once or twice a year, you know, so you can quickly look at these issues. Your medical aid will actually reward you if you do those tests and stuff. So these are simple interventions, and I think sometimes, even as young people, when we're busy studying and we lead full lives and we have to have a secondary job to help us pay for our studies and stuff, there's little things that we can do that will help us. And the younger we start, the better, because trust me, when you're already overweight as a 10-year-old schoolgirl, and you don't get educated or you don't get informed by health promotion programs, it's not going to change when you're 20, it's not going to change easy when you're 50. can actually get progressively more difficult. So it's also about us making ourselves attuned. Even if you're not a healthcare worker, we've got the engineer where he manages people. It becomes a responsibility to say to people, you know, you've got to be careful about your health because you're affecting your income stream and a range of other issues. Okay, thank you very much for your time and your attention. Enjoy the morning with you. I hope you've learned something. It was really great. So thank you very much.